Okay, so welcome everybody to Cancer Bridges General Weekly Support Group. This evening, we have Dr. Ferguson, who is a clinical psychologist and associate professor of medicine with the Division of Hematology Oncology at the University of Pittsburgh School of Medicine and UPMC Hillman Cancer Center. His clinical and research interests are the treatment of cognitive effects of cancer, cancer survivorship, and palliative care. He is the lead author of Memory and Attention Adaptation Training, a brief cognitive behavioral therapy for cancer survivors. He has also authored numerous peer-reviewed research articles and book chapters on the treatment of cancer-related cognitive impairment. His research has been funded by grants from the National Cancer Institute, NIH Office of Research on Women's Health, and numerous private foundations. And I've known him for a while, and his program really works. I've used it on a couple of my clients, and so we're really excited to have him here. So welcome, Dr. Ferguson.
Well, thanks for having me. Once again, this is great, and thanks everybody for taking the time to let me talk today. So I'm going to, that was a generous introduction. Thank you.
You're welcome.
I'm going to try to share my screen, and I think we're going to be okay. Can everybody see those slides? I'm going to put it on presentation mode. Just a second, please. How's that? Okay, good.
Looks good.
Fantastic. Okay. So tonight I'm going to try to be as interactive as possible. So if you have a question, chime in. I'm going to go through a little bit of background before this problem of cancer-related cognitive impairment, and then a little bit about the cognitive behavioral approach to managing this problem, and getting down to brass tacks about what adaptive changes people can do. And if you have questions along the way, please chime in. I like to have this interactive. I've been doing more and more live talks, and I've forgotten how fun that is to see facial expressions. So don't be shy and raise your hand and we can go. And I'll save plenty of time at the end for a question and answer session. Just a quick disclosure. I mean, one of my, I guess this is a good conflict of interest, so that I authored this treatment manual. We have a manual that clinicians follow, as well as a survivor workbook published by Oxford University Press called Memory and Attention Adaptation Training. And these are some of my funding sources of current and past research. Now, I don't have to tell this crowd, but we've never had as many people with a diagnosis of cancer in their lifetime as we do at this point in history. There are 22.2 million people who've had a cancer diagnosis in their lifetime. So the National Cancer Institute defines a cancer survivor as anybody who's had a diagnosis of cancer, regardless of where they are in the cancer experience. It could be very early on during active treatment, or many years after active treatment is finished. By 2030, I'm sorry, right now we're at about 18.2 million. By 2030, we're anticipating 22.2 million people with a cancer diagnosis. So why is this important? Because while we can get people into remission, we've had great success with early detection of cancers, more targeted therapy of cancer, but the symptoms and side effects of either treatment or disease itself can linger on for a long time. So far as we know, with mild to moderate cognitive impairment, those symptoms seem to be quite persistent for many years. It's not everybody, as I'll go into in some detail, but with these large numbers of survivors, it's incumbent upon us to try to manage this problem. And it's not going to be all one approach. It's not one size fits all, because there's many causal factors to the problem. Hopefully my slides will advance. That's not moving, is it? Here we go. And these are just some of the numbers of cancer survivors we have in the US. You can see Pennsylvania is near 1 million people. You go to my home state of Maine, it's just a little bit under 100,000. but our population in the state of Maine is only 1 million people. So you've all heard this term called chemo brain. I just want to let you know that yes, chemotherapies can be a causal agent. Some chemotherapies can cross what we call the blood-brain barrier, that certain agents can get into the brain itself. Usually it's drugs such as cyclophosphamide or 5-FU, and those agents have been known to cause neuron dysfunction in the hippocampus, which is deep organs in the brain that or areas in the brain that process memory. So over the years, we've also known that cancer itself can cause, whether it's a central nervous system tumor in the brain or somewhere else in the body, say breast or prostate cancer. Immune system responses can also cause some of this cognitive impairment we see even prior to the initiation of any systemic therapy or cancer treatment. So this term cancer-related cognitive impairment is what a lot of research investigators have settled on. And what is cancer-related cognitive impairment? Well, it turns out there's sort of 3 areas that tend to be affected with neuropsychological testing of people who've had cancer and have memory problems. One area is verbal memory, so remembering words, what other people said, or something that you've read. So verbal content and recalling that later. Some people on the call might have had a family member say, we just talked about this about 2 hours ago. Don't you remember me asking you that question or having a discussion? Also with working memory is that memory where if Wendy told me a phone number and I went to go tell somebody what the phone number is, but while I was walking down the hallway, somebody said, hey, Rob, how are you doing? I got into a conversation. Where did the phone number go? So it's holding something in your memory long enough to take some action. Another area that tends to be affected is slowed processing speed. So being able to pay attention, say steps in a task, or listening to my words and wanting to take a note, it might be hard to keep up. It might be hard to track steps that you're taking in action, or your reaction time might be a little bit slower. You may find that fatigue will usually affect that at particular times of day. So those are the 3 major areas, but there's all sorts of manifestations in daily life, such as misplacing objects. I found out before this call, I made a salad dressing and a salad. I go, I have to eat something before I get on this call at 6 o'clock. So I made this little salad and I had a jar of mustard and I used, vinaigrette and some olive oil. So I put the mustard in the pantry. So that's a working memory thing. It's also, there's a little bit of processing speed because I was kind of tired when I was doing that. Anyway, those are some of the daily memory failures. We don't know the exact prevalence of cancer-related cognitive impairment. We think it's about maybe half of all survivors. It really depends on the cancer diagnosis, whether it's a hematologic disease such as leukemia or lymphoma, or a solid tumor cancer such as breast cancer, or a cancer that originates in the brain such as a glioblastoma or other type of brain tumor. But suffice it to say, for people with non-central nervous system disease, tumors in other parts of the body, we think it's about right around half of all people 1 year after active treatment can have these mild and moderate cancer-related problems or problems in memory and attention. As I said before, it tends to be verbal memory, processing speed and attention, and working memory. The other kind of interesting fact here, we used to evaluate in the first probably 2 decades of research on this problem. We used to evaluate patients that had already been exposed to treatment but we needed longitudinal studies. So we needed people that were early in diagnosis and match them to people that would get two different types of treatments. So for example, breast cancer patients that would go on to systemic chemotherapy, and breast cancer patients with the same stage of disease who wouldn't. And we'd also match them to age and education variables, or people who don't have cancer. And what we found when we started doing those type of longitudinal studies, that up to 40% of individuals before starting chemotherapy had a mild to moderate level of cognitive impairment. So it wasn't just the treatment that was causing these memory problems. And what we believe it is an immune system response. That when we start off with a systemic disease, heart disease or cancer, there's an inflammatory immune response. And pro-inflammatory cytokines are substances that get released whenever we have any type of invasion. And we think that one of those cytokines, we call it IL-6, tends to affect the hippocampus and processing of memory. It doesn't happen in all cases, and that's sort of the mystery, is why isn't this everybody who goes through cancer? It certainly isn't by any stretch of the imagination. There's quite a bit of variation depending on disease and type of treatment the problem of the person gets. We also know that we need more research. Probably up until about a couple of years ago, most of the research on cancer-related cognitive impairment was done among breast cancer survivors. We are now catching up with other cancers such as lung cancer, B-cell lymphoma, leukemia, those people who've undergone stem cell transplant for those blood cancers, prostate cancer, and other solid tumors such as sarcomas. We're seeing a greater variety of different cancers being evaluated. And we've done a better job at standardizing the neuropsychological tests we use to objectively measure memory and attention performance. And the interesting thing about memory and attention performance on objective neuropsychological tests is that when we give people a questionnaire, say you get a questionnaire in your medical oncologist's office, and you have some questions on memory, and you have to rate from 0 to 4 how much the symptom bothered you. Those standardized self-report instruments tend not to correlate or be associated with the objective memory performance, but they do help us give some insight into what the person's daily experience is. When you do a neuropsychological test, you usually are in an office or a very quiet setting, and you're not performing with competing demands. So that's one thing that we found very consistent in the research, that self-report measures tend not to be associated with objective neurocognitive testing, but they give us insight of what the person's daily life memory and attention problems are, where the neuropsychological test is rather laboratory based. And we also know that during when we have done studies of the brain with functional imaging, and I'll show you some imaging on a slide coming up, that there appears to be changes, particularly those people who've been exposed to chemotherapy, with the prefrontal cortex, so the front part of the brain that tends to be devoted to attention and memory and being able to make quick decisions and processing speed. We know in at least the breast cancer population, it tends to be atrophied, but the cerebral cortex, or the outer part of the brain, tends to have greater neural networking to compensate for that. So brain structure and functional changes happen in non-central nervous system cancer. And that's consistent with some of the reports that people get. And I'll show you a slide on that. So this very busy slide, I'll just go through it very quickly, that I've gone over some of the causes of cognitive dysfunctions. Certainly, cancer treatment itself, I told you chemotherapy can have a direct effect on neuron or brain cell health and structures of the brain important for memory, such as the hippocampus. Pro-inflammatory cytokines can also inhibit memory and attention function. I didn't go over endogenous hormones, but we know that with drugs that reduce estrogen availability, so either chemotherapy-induced menopause or being on an aromatase inhibitor or tamoxifen to prevent breast cancer recurrence can affect verbal memory. So brain estrogen is important for verbal memory, remembering words, remembering what you read or what you heard in a conversation. The same thing with androgen deprivation therapy for men with prostate cancer. So those hormonal treatments are important to keep to prevent disease recurrence, but people can have who are on these medications can experience these long-term verbal memory problems. Some cancer treatments can cause microvascular damage in the small and tiny blood vessels that bring oxygen and nutrients to the brain. And genetic markers. There's a genetic marker called the apolipoprotein E. ApoE for short. Now, ApoE positive individuals in heart disease who undergo open heart surgery for coronary bypass, ApoE positive individuals have a greater tendency to show post-surgical cognitive problems versus those people who don't have that genetic marker. And we think that's partly because of microvascular changes, that people may be more vulnerable to that, as well as the ability of the blood vessels in the intracellular space, the tiny gaps between the blood vessels and the neurons, of essentially pumping out toxins. But we've seen mixed results in our cancer-related cognitive impairment research. So some studies have shown an association between ApoE positive status and cognitive problems, and other studies have not. There's some very interesting new data on why that may be so, but we still just aren't very clear on that. So I told you that the neuropsychological testing scores, what's interesting is many of the neuropsychological testing scores that people will have done, if they've had this problem, they've gone to a clinical neuropsychologist. And the neuropsychologist says, well, your scores aren't that bad. They're really in a normal range. The question is where was an individual before their cancer treatment? And are there relative weaknesses that that person may have? Maybe not so much in auditory verbal memory, but in words that are written. So there may be very specific impairments, but those impairments may not show up unless the person is doing something quite active. So the greater the memory demand on the person and the greater the performance demand, that's when you may see some of the cognitive problems show up. I can show you an illustration of this, and some of you might have seen this slide before, but this idea that memory problems occur under greater demand than at times that are relatively normal and fairly easygoing. What this slide is of two identical twins. This is a long time ago, probably in about 2003 or 4. I was doing a study on memory and attention adaptation training, and one of the participants was a 60-year-old nurse. She was semi-retired. She had kind of a stressful life because she had a son who had schizophrenia, and she was his caregiver. He was semi-autonomous, but she had to provide some supervision. She indicated to me that she stopped her hormone replacement therapy right at the moment that she had heard about her breast cancer diagnosis, and she called her twin. And at the time, we were doing an ApoE brain imaging study down the hallway. And so I immediately thought of a twin study. So I asked her, are you an identical twin? And she said, yes. And then she said, but my twin sister lives in Virginia, and I was up in New Hampshire at the time. And then she said, well, my twin sister works for the airline. She flies to Manchester every day. I said, well, bingo. Okay, we have a twin study. So we got them, she flew up. We tested them both on neuropsychological tests. Our breast cancer twin had already been neuropsychologically tested. So we had to test her non-cancer twin sister, who she didn't develop breast cancer. So we had kind of a natural control condition. And when we tested them for their identical twin status, they turned out to be their genetic copies, so they're identical twins, and they're both ApoE positive, which was even more interesting. On the top, you'll see that's the twin who had breast cancer and chemotherapy. The twin on the bottom is the twin who didn't have cancer. What you're seeing in the orange and yellow shaded areas is blood flow, and going left to right, each twin is doing a task in the MRI scanner with a periscope on, and they're pressing a button each time they see a target letter with a series of letters going left to right. And at first, you only can press the button when you see the target letter just one back before. So, and then when you see the target letter 2 back, and then 3 back, it gets more difficult. So more brain is being used in both twins as the task gets more difficult. But clearly, more brain is being activated in our breast cancer twin. Now, what was interesting is they both performed objectively about the same on neuropsychological tests, where they performed about the same on the task in the scanner. Where they differed was the self-report questionnaire that was filled out by both. Our breast cancer twin was essentially telling us they're having more cognitive problems in daily life and tasks that they do, and they're having to work harder to get the same performance. So we thought this picture here is worth 1,000 words. So investigators throughout the country started replicating this with groups of 25 or 30 survivors, and they found the same sort of findings. So while objective neuropsychological tests are good tests, but they're kind of crude instruments to really identify more severe deficits and not these more subtle ones that occur when a person is busier and when there's more memory demand. Any questions on that? I hope I explained that fairly clearly. Okay. It turns out that stress hormones such as the glucocorticoids, or these are essentially cortisol steroids that are released under stress along with adrenaline and noradrenaline. And we need an optimal amount of glucocorticoid, or particularly in the frontal lobe regions, to remember well. And it turns out we get a dose of glucocorticoid upon awakening, but it's very low in our system. So we all have that time when we wake up very early in the morning and you look in the mirror and you can barely recognize who you are, right? But then as we go throughout the day, we release more cortisol. We tend to get 2 receptors in the frontal lobes of the brain that start to have uptake, and our memory performance tends to improve. It starts to decline around 2 in the afternoon. So more analytic tasks or more cognitive heavy tasks, we have to do a lot of reasoning or planning, probably better off in the morning. Toward the end of the day, these receptors become saturated. So even though you have more stress going on, more release of cortisol, the receptors on the neurons, particularly in these frontal lobe regions, tend to be saturated. So this can affect things like memory recall and processing speed. So the bottom line is we need optimal arousal to have peak performance in memory and attention. Save those repetitive tasks that you have to do that are kind of mundane for the end of the day. So just to recap, cancer-related cognitive impairment isn't one thing. It has multiple causes and multiple mechanisms. So there's a host of biological and pharmacological agents that could be helpful, but we haven't found one in particular that stands out yet. There's also been a lot of research on the improvement of cognition with exercise. So the jury is fairly back. Those people have a physically active lifestyle, and it just has to be simple walking or weight resistive training. When people are physically active, they tend to have better cognitive performance. Also, gaming, rehabilitation, computer generated repetitive practice is helpful, particularly when the computer program can manipulate the success rate of performance of about 85 to 90%, and then it'll make the task more difficult with its coding each time. Those things have been helpful, but one of the limitations are you may be very good at that task on the computer, but it might not help you remember what the action step it is that you promised, either at your church committee or something that you had to do at work that somebody told you about. Or it may not help you remember where you parked your car at the airport. I know that also a lot of my work, but in our research surveys have suggested that many survivors have been through a host of cancer treatments, all sorts of drugs to help manage side effects, that probably not another pill would be something that would be desirable for cancer-related cognitive impairment. So, as with conditions that are chronic, such as chronic pain, a cognitive behavioral therapy approach focuses on functional improvement. How can we functionally overcome these small memory impairments, particularly when the memory problems that interfere with quality of life tend to happen at greater times of demand for cognitive performance? And how can we address those targeted times and those inconsistent patterns with better awareness and then more effortful adaptation in daily life to either prevent the memory problem from occurring in the first place or finding some sort of compensatory strategy to contend with it. And that's why we've taken this cognitive behavioral therapy approach. Any questions to this point? And this is the smartest group I've spoken with in a while. Okay, I can see some of you, but not all of you. So we came up with this cognitive behavioral therapy program called Memory and Attention Adaptation Training. And I don't know if people are familiar with the term cognitive behavioral therapy, but it just simply means modifying thinking that can become habitual, particularly when you've been through an extremely stressful event like a life-threatening illness such as cancer. That's been hugely disruptive in that. And modifying behavior, thinking and behavior, cognitive behavioral therapy. They usually are very short-term and to the point for psychological treatments. And memory and attention adaptation training is 8 visits long, maybe once per week. Each visit is about 45 minutes. We've designed this to be telehealth delivered. I've been doing telehealth since 2010, so the pandemic was nothing new for me. When I first proposed doing telehealth delivered cognitive behavioral therapy, it was in the early 2000s, and a reviewer called it preposterous. And the reason for my proposal is when people have gone through extensive cancer and cancer treatment and have burned their paid vacation, maybe their bank accounts. If you're a psychologist at the Comprehensive Cancer Center, I don't think people who live 3 hours away from the cancer center are going to come back for 8 visits to see the cancer psychologist. So we have to go to them. And it's not just about reaching people in rural settings. That's true. But transportation time and time away from work or family or childcare is incredibly burdensome. I don't have to tell people who've been through cancer this. So finally, after about a decade, the National Cancer Institute listened to that pitch, and they started funding telehealth delivered cognitive behavioral therapy for this problem. So we follow a standardized manual. So if you get memory and attention adaptation training at City of Hope in California, I just trained them last week. It'll be the same that you're going to get in Lewiston, Maine at the Patrick Dempsey Survivor Center, or if you get it in New Zealand. So that's why we've standardized this. There's also a survivor workbook that you follow along with. The workbook is handy because if you don't pick up on something that you and the clinician covered or you forgot it, it's there in the workbook. We've done 4 clinical trials now. We have a clinical trial open at Hillman Cancer Center where we're doing brain imaging pre and post as well. And I have a colleague at Indiana University. I'll tell you more about that study. But we found that MAT, for short, memory and attention adaptation training, can improve neuropsychological test performance with verbal memory or processing speed. But also the self-reported cognitive problems of daily life, those standardized questionnaires, we've seen improvement with that. It consists of education and reattribution. What do I mean by education or reattribution? First, we go over a lot of what I just told you in the first part of this. There's multiple causes. It's not everybody who goes through cancer. Many people will clear up after their cancer treatment and will be just fine. But there are some people whose symptoms may persist for a long time. This idea of reattribution is a very important notion to understand, which is human beings have this tendency when going through a stressful thing, let's say a brain injury such as a sport-related concussion, and we ask people, like, how many symptoms do you have in daily life? And they'll check off on a checklist the number of symptoms, let's say 6 on a symptom checklist of 12. And if you ask people who've never had a concussion before, how many symptoms do you expect to have after a sport-related concussion? They will write expected symptoms with a correlation will be about 0.9. So if you go to 0 to 1, this is a very strong association with expected symptoms by people who never had a concussion, and those people actually had them. And what's interesting, that expectation set, when a person recalls what their memory and attention function was like prior to their concussion, the people with a concussion will report about half as many symptoms in daily life as healthy controls. We found this with age-related cognitive change. If you ask 80-year-olds how many symptoms they have in daily life of cognitive problems, they'll report about the same as 35-year-olds. But when you ask the 80-year-olds how many symptoms they had when they were 35, they will report about half the number of symptoms as the 35-year-olds. Now, this is just, we call this expectancy guided recall. We kind of remember things that are consistent with our experience, and it may not be entirely accurate. So we point this out to survivors, and for the simple purpose that you may have a memory and attention failure in daily life. I put the mustard jar in the pantry, not back in the refrigerator where I found it. I could have left it there overnight and spoiled the mustard. Okay, I might have done that because of my cancer-related cognitive impairment, but it might have been also the time of day. So we want to help people be aware of this process so that not every memory failure may or may not be attributable to the uncontrollable experience of cancer, but to more controllable things such as inattention or fatigue, and in those at-risk situations. So our self-awareness component of MAT is we have people keep standardized diaries or memory and attention problem records, and where and when they tend to have memory failures that are bothersome. We all have memory failures each day, but where are the ones that get in the way of interfering? It might be something with collating or filing at work, and that might be a critical job performance task. So what we do is we help people target those situations and then come up with a compensatory strategy to deal with that. We also teach stress management skills. When we're under greater stress, we tend to have blood flow changes in the brain that won't allow recall functions to be as efficient, because the brain will be looking for the escape routes through the senses of vision and hearing. And it's very difficult when you're stressed to do a quadratic equation in your mind. So we want people to cultivate optimal arousal to improve daily memory and attention. I'm not going to go over this slide because I'm looking at the time and I want time for questions and answers. But one thing that we want to do with this cognitive behavioral therapy is make sure that we help people identify where and when they're at risk for memory problems, and understand that not every memory problem may or may not be attributable to cancer. Sometimes when we have a confirmatory experience that's consistent with our expectation, that causes more adrenaline, cortisol release, which can affect the blood flow processes that I talked about for memory and attention. And you get caught up in this positive feedback loop. And we want to break that cycle by being aware of that human psychological process, and then start to develop compensatory skills to work around those daily memory failures. That's what that busy slide is all about. I told you we delivered over telehealth. Here are the 4 components. Self-awareness training, again, is just keeping a record of where and when you'll have memory problems. We also teach people, believe it or not, to talk to themselves through tasks called self-instructional training. What's interesting is that this actually comes from reading comprehension literature. Turns out when we read to ourselves silently, the neurons or the nerve pathways going to the vocal cords are activated. They aren't moving the vocal cords, and the vocal cords aren't producing sound because we're not speaking, but we're reading. So there's something about this entire motor unit represented in the brain, and these motor neurons to the vocal cords have to be active. They've trained kids who had poor reading comprehension to read out loud to themselves. When they put surface electrodes over the throat, when the kids start to read silently with their lips closed after reading out loud, then those vocal cord activation that weren't active before are now activated, and the comprehension scores go up. So using more brain to get around potentially damaged circuitry elsewhere is the idea. So we actually have people talk to themselves through tasks. I put a gasoline truck here because one of the patients I had who drove a gasoline truck, there's a series of valves you have to turn off and on in sequence. You don't want to mess that up to prevent a spill. You also have to ground the gasoline truck because it takes on an electric charge when you're putting gasoline at the distribution center. And he was terrified he would cause some sort of accident. But we use self-instruction to go over the procedure as well. And then he didn't come back because, good enough to go. So that was a good success story. So there's self-instructional training. We train people in progressive muscle relaxation to relax muscles, to optimize a person's arousal, and teach people how to manage fatigue. That is, shift tasks before you get tired. Fatigue in cancer is related to pro-inflammatory cytokine release. Again, the cytokine IL-6 is associated with that, but that's an imperceptible release. You can't feel that. But oftentimes when we get busy in our daily lives, we kind of wait until we're tired before we get up and take a walk. Or, and I mean just maybe 1 minute, walk around the room, or go downstairs, or go to another part of the office, or just go outside quickly and then come back. But to do that in a time contingent way, not in the subjective sense that I'm getting tired. When we do that, we can help reduce fatigue related cognitive failures in daily life. So we teach people these compensatory skills. We also teach people how to identify and modify habitual negative thinking that can spawn distress associated with memory problems in daily life. And helping, for example, some people may overestimate the probability that a bad or negative outcome could happen with a memory failure. And we actually do the math. Out of the last 10 times you forgot your daughter at soccer practice, how many times did you actually, well, I didn't forget her 10 times. Well, how many times have you ever picked her up at soccer? Probably 100. How many times have you forgotten her? Once. So there's a 99% probability you're going to pick her up and you're not going to forget her. So we teach people methods of challenging thinking, using as much objective data in their life as they can. And we help people keep a daily schedule, how to schedule events and take away the burden of trying to remember tasks from the brain. It doesn't mean write down everything. We actually tell people to eliminate to-do lists. In the time management and stress management literature, to-do lists are a culprit of actually inducing more stress. Anybody know the average number of to-dos people write down? It's about 8 to 12.
Yeah.
How many get done?
2.
Yeah, 2 to 4. So the reason why they don't get done is because there's no information about how much time each task takes. When you put it on a day planner or on your smartphone calendar, some people prefer paper, doesn't matter. You have to account for the time. So going to pick up the dry cleaning can be at least a 20-minute endeavor if the dry cleaner is close by, because you have to get into the car, go to the dry cleaner, or you have to walk there, wherever the dry cleaner is. So accounting for the time. And so these are some of the compensatory strategies we do. Because of the time, I kind of wanted to just go forward and ask you if there's any questions, and I can tell you about our study later. But I just want to open up for discussion.
Yeah, you know what, Rob, I'm going to actually stop the recording so that we'll bring everybody back so we can see you. That would probably be.
Okay, I'll stop sharing.
Yep.